on, and you just have to not wander.
Thank you. So can you hear me through this? Oh, really? This one's number 2. Can you hear me? No. 2. That's better. Yeah. Okay, good. All right, thank you. Yes, as Michael said, rather than introducing today's speaker, who is unwell, I then found myself now filling out the time that she was going to. So you're going to have to listen to a talk which I'm hoping you will agree answers this question about how to provide leadership for industry transformation through innovative, discipline-relevant and responsible data science. I want to talk about my profession of clinical psychology and why it needs to engage with people like yourselves around using data. And where I want to end up is with a model like this, where here is all of the elements where I think that the data can be helpful. And where I want to start is with a lecturer at UWA in the 1980s, Robin Winkler, who it's significant for me because he was speaking at the very first psychology conference I ever went to, and he gave this address, and I didn't go to it. But because I didn't know who he was at that time, but I did read it afterwards. And he was talking about, he'd conducted a review of the way clinical psychology was at that time, and was talking about what the strengths were. And he was saying it had a strength because it linked the scientific discipline of psychology with professional practice, that it was leading to improved standards by which interventions for professional practice were being evaluated, and it would allow the development of new and effective procedures. But he did highlight a warning. He said the major threats stem from its very success in professional practice. There's a continuing demand from the profession to learn techniques without necessarily understanding or developing their theoretical and empirical foundations. The danger of such is that what he was talking about then, behavior modification, we can say psychology, becomes simply a technique defined by its procedures. So here he was at UWA arguing this is the major threat to the profession. So where are we now in 2024? If you look on the clinical psychology website, you can see, if you type in what is clinical psychology, it is a profession that uses a range of techniques and therapies that we tailor to a complex array of problems. So in fact, if you look at what the profession is saying, it is now a profession defined by its procedures. So it has become what was being warned against. So how can people like you assist people in a profession like mine? The first is we have all sorts of problems. That there are millions of studies in clinical psychology that look like this. They compare 2 active treatments with a control, and what they find is that the 2 treatments are more or less the same. They're superior to the control. Sometimes on some measures you find one is superior to the other, which has led to the reference to Alice in Wonderland, that all have won and all should have prizes. So there's this, what are we going to do? And in fact, when you have a look at what clinical psychologists are doing, they're generating more data. So if we pick one of the important therapies, cognitive behavior therapy, one of the major problems, depression, you find across the years, there have become more and more and more studies. And what have they found? There's a really interesting conclusion in this paper which says, we found that studies conducted after 2011 have larger effects than those prior. Well, that's good. We're actually improving. I looked at that and went, don't believe it. See Table 5 for supplementary information. So being the diligent data scientist I went and had a look at all 196 pages of Table 5 and waded my way through it to find the numbers that are referred to that led to this graph that they're referring to at this point. And lo and behold, those are the actual data that you find in the supplementary table in Table 5, which is, yes, prior to 2011, there's what it was. But if you go back to the earlier studies, you find there was no difference. There's some nice cherry picking of the data. So in other words, treatments haven't been getting more effective over time. We've just been doing more and more studies showing the same thing over and over and over again. Not very good. So what is the solution? Well, I want to point out to you how deep this problem is for my profession. One is, if you ask clinical psychologists to predict what the outcome is going to be, what they predict is most people will have a positive outcome. Some will show no change, and this is out of the 550 or so patients, they predicted 3 would have a negative outcome. This is despite working a clinic where the clinicians were told that we have about a 10% deterioration rate. Even so, they only predicted 3. Interestingly, compared to the actual data, what you can see is they underestimated the number who deteriorated. Worse than that, they completely predicted, or they failed to predict the actual ones who deteriorated, and they over-predicted the success. Okay, so they might not be good at predicting. Are they any good at describing? So I looked at those data. We grouped those into those who were clinically significantly improved right through to those who got significantly worse. And we asked the clinicians, how would you rate these people in terms of the symptoms? And what you can see is, well, the good news is when people left treatment, those who were significantly worse, they were saying, yeah, they have more symptoms than these. But actually, they thought all of them had improved. So we've got this continual overestimation. Why is that? Well, it's probably because there's a survivorship bias. Like the people who were looking at the planes that came back after World War II and looked at the areas where the ones that got shot and said, oh, we have to reinforce those bits where the bullet holes are. Only to realize that actually these are the areas you should be focusing on because these are the ones that never got back after all. And clinical psychologists do this all the time because, say, here is a clinical psychologist like Michael Small, treats somebody, some of his patients will stay and improve, some will drop out. He'll never see them again. They then might come and see me. So I look at them, they turn up and they say, I've just seen this really bad clinical psychologist, Michael Small. I go, oh, he's a really bad clinical psychologist. They stay with me and they may improve. So I go, I'm a good therapist, he's not a good therapist. But some of mine will drop out who I'll never see again, so I'll never think about them. They will go off and there'll be another therapist who'll go, oh, Andrew's not a very good therapist. And so we'll form this impression that I'm a good therapist, everybody else is a bad therapist. So how does data science come into? Well, one of the things that modern methods like imputing data are able to do are to carry out imputation of data for a clinical psychologist for the people who drop out, who you don't have extra data for. So we can start to select treatments using that. And so there are techniques. So some of the areas where machine learning are used are in a procedure called the Personalized Advantage Index, which I'll just describe briefly. if you have a set of predictors and you have some people with treatment 1 and some people with treatment 2, then you look at them at the end, you can measure how effective was that treatment in achieving the outcome. As long as you've got common predictors, you can also work out what the predicted outcome would have been had they been assigned to the other treatment. Using the more sophisticated measures you use, the more accurate you can get at being able to do this, and then you'll be able to identify people who were assigned to treatment 1, who that was the treatment where they were going to have the best outcome, but there are also other people who would be assigned to treatment 1 who, had they been assigned to treatment 2, would have been their preferred treatment. So then you can start to build a model where you can identify people at the beginning and match treatment to them. The other way we can do this is a colleague of mine, Jamie Delgadillo, in the National Health Service. Australia is exactly the same as this. We have stepped care. If you have a mental health problem, you go to your GP. If you fail, they'll send you to a psychologist. If you fail, or a psychiatrist. If you fail, they'll go to... So you have to fail to proceed through the healthcare system. We can call that stepped care. The alternative is stratified care, which is right at the beginning, you match the person to the treatment based on that, so they don't have to fail through the treatment. And what you can see here is it's actually more effective if you do that. Probably not going to be very popular because it's more expensive if you do that, but it's more efficient. And so, step 1, we need to use data science to have personalized treatment selection. Step 2, if you look at people at the start of treatment and the end of treatment, they improve. Psychologists love averages. If, on the other hand, you look at what is behind this average, this is a group that we ran at UWA a few years ago, it just shows that that average is driven by a superstar who improves, some others, but most people aren't going that well. And if you have a look, sorry if you're thinking about seeing a clinical psychologist, because this will be depressing, about 60% show no change. So we need to monitor progress rather than waiting till the end. We need to have, as well as personalised selection, we need personalised adaptation. So we adapt treatments along the way. So this is what we have started to do at Perth Clinic, where we identify a personalised expected trajectory of improvement, and then we look at the actual improvement every day. Obviously, I've just shown you somebody who's an absolute superstar. They're improving, but the interesting ones would be those who are not, their well-being is not improving as expected. Their symptoms are not dropping down as expected. What we find, if you do that, if you provide feedback, you don't have to provide any extra treatment, you just provide feedback to the patients and the clinicians, you get improved treatment outcomes. So it's, clinicians know what to do, they just don't know with whom to do it until you provide them with those data. Even works in the United Kingdom as well. So then we said, okay, well, if it works there, what about with suicide risk prediction? So this is some of the work that we've done with Michael Small and colleagues. And this is why we need it. In 2016, the American Psychological Association said that our analyses showed that science could only predict future suicidal thoughts and behaviour about as well as random guessing. This was extremely humbling after decades of research. Yeah, right. But they then said, in the next panel, risk guidelines should not be abandoned. As most of these guidelines were produced by expert consensus, there's reason to believe that they may be useful and effective. It's like, on what grounds? So this is why professions like clinical psychology need data scientists. We're just useless. And why it's helpful, so if you're predicting suicide, when we were talking with Michael, we were saying, well, one of the reasons why they probably do this is we're trying to predict it from data that we have rather than thinking about what is the data that we should be collecting. Suicide risk is not a trait that one carries around with you. It's a state. It comes and goes. And if you look at these people here, these are two people who on this day have very elevated risk, but these are hypothetical where their trajectories are quite different. But if you run a regression line through them, you'll say this person hasn't got risk, this person has got risk, and you will miss that. So you need to measure during. And so this is what we started to do at Perth Clinic, and we found that actually, even if you just ask a simple question, have you thought about killing yourself? People who are high on one day but drop down by the next, their probability that they'll self-harm when in hospital is relatively low. But if they're high across 2 days, then you've got a 1 in 4 chance that they're going to self-harm while they're in hospital. So then we said, okay, well, that's good. Which day are they going to identify? So we brought that together with that tracking. And so what we could see is that, yeah, this is suicidal ideation is increasing on the days before T0, which is these are people who self-harmed versus those who didn't. You can see it's increasing. But also there are other variables that I'm not going to talk about, which are already increased and increasing in the days prior to a self-harm event. So then what we've done is used some machine learning algorithms to help us to see if collecting data during an admission improves our ability to identify when a self-harm event will occur. Thanks, Michael. From just the data we have at admission. And what you can see, if we just look at, this is the sensitivity. It makes no difference in the sensitivity of our prediction, but in terms of the specificity, we improve the precision of prediction over and above the information that's just available on admission to the hospital. So understanding when a person is at risk helps us identify the particular day. So another example where the machine learning AI can assist us with that precision care. So we've had personalised selection, personalised adaptation. Now, what about the therapists? This is the bit, when I talk to clinical psychologists, they really don't want to hear, because they like the idea that their patients can change. They don't like the idea that they might have to change. And here's why they do. Remember, when you give feedback, which is time 0 here, for those patients who are on track, giving them feedback that you're on track didn't change anything. That's good. But for those who are not on track, actually you can see it jumps up almost instantly. So you'd say, oh, well, that's... So the therapists should be using that, and especially with those patients who are more severe. And so inpatients are going to be more severe than the outpatients. What we actually find is that feedback was given, so we didn't tell the clinicians who to give feedback to, they chose to do it. You can see they chose to do it with, on 1 in 2 of the patients who were the outpatients, but only a third of the inpatients. So the patients who were more severe, who needed the feedback, they weren't giving the feedback. This is why we need therapist feedback systems as well, which is an area that the profession hasn't even moved into. These are some UK data in the National Health Service, and here's why we need it. What you can see is that the probability of dropout for most therapists is around average, because that's what the average is. But what you can see is there are some therapists who have very low rates of dropout compared to everybody else, and there are some who just can't seem to hold their therapists at all. The same for probability of deterioration. Interestingly, there are some therapists, these ones in this quadrant, who have low dropouts and low deterioration, but what you can see, it's just a big blob. And there are some people who have fewer dropouts, but they have more deterioration, others who have more deterioration and fewer dropouts. But the therapists don't know which ones they are, which is why they're leading to that survivorship bias. So we need colleagues like you to be engaging with the profession to be able to improve that and to address the cognitive biases that they have. And that's why I began with the scream, because lots of people think that the scream is that this is the person screaming. No, this is the person who's got their hands over their ears because somebody else is screaming. This is the profession of clinical psychology, looking at the data, putting their hands over their ears. We need you to help them remove their hands, show them the data, help them understand the data. And I don't think clinical psychology is unique in this. Thank you.
On the shelf, but we'll take questions. If anyone's got questions for Andrew? I'll start. So psychologists don't like error bars in their box.
That is true. Some do, some don't. You would have seen the ones.
You're halfway through this.
Yes. They had been, since I was presenting it to a group of therapists, I had removed the error bars to make it nice and simple for them so they didn't get confused. Those who have come through UWA's Combined Masters PhD program love error bars, but those who haven't, so I was, there's a plug.
Excellent. I think question first.
Sorry.
First, yeah.
For the therapist dropout and duration, some quite interested in looking at the various different personalities or the subgroups, because having friends from, for example, ADHD diagnosis, I know that if they are, there you go. Loudness? Okay. They have a tendency to, if visiting psychologists or specialists that aren't within that profession, perhaps would drop out.
Yeah. So the question was about, are there different groups of patients who are more likely to drop out? And the answer is yes. The focus of this research was looking at what are the therapist contributions to the dropout. What you find is that the therapy itself is about explaining about 6% of the variance in dropouts, and the therapists are explaining about 6% in the dropouts. The remainder is due to the individual and other stuff. So.
Yeah, thanks, David Kavanagh, Integrated Energy. Thanks for a great talk. I was really interested in your stratified model. And I wonder if you could extend it a little bit into multidisciplinary teams where the psychologist forms part of a team with other disciplines to maybe assess rare conditions or things that are a bit deeper. Have you done any similar analysis of the effectiveness of multidisciplinary teams, including psychologists?
I haven't, since the clinic that I was doing most of the work with had lots of patients but relatively small number of therapists, so we weren't able to distinguish. We were able to look at different groups, and so what we have been able to do is show that different therapists providing different treatments, so we've been trying to build the models of dropout during treatment. So what we found is that there's not a model of dropout, there are different models that are required for different treatments. The those data that I showed you here, these ones, as you can see, they've got lots of individuals. These are based on the National Health Service in the Sheffield area, and so they have done those sorts of analyses. I would really like us to be doing this. I have struggled to be able to get our health services to engage in processes like this to answer those questions. So, so Michael know this, we've engaged with the NHS in the UK and they are implementing the models that we're developing here, but we've struggled to be able to get the implementation within Australia, which we need to do.
I'll just give one more question, and then I have to get Andrew to move on to the next speaker.
Thanks. Is there a culture within clinical psychology around reproducibility of studies, or is everyone just trying to do the next thing?
So is there a culture around reproducibility? Yes, there is a culture around reproducibility in the sense that most of the systemic drivers are towards generating new results rather than replicating old ones. That is changing, but I think like most professions, and most it's not only professions but most disciplines, all of the pressures are around generating that new result so you can win a Nobel Prize rather than the systematic build-up of science. But I must say that there are cultures within areas where they will look to replicate and extend findings, and there are now lots of journals that won't publish just the one study. They will require a replication extension, and so that culture is changing in response to the acknowledgement that there are lots of areas that can't, or lots of findings that haven't been reproduced.
Thank you, Andrew.